Hi, this is Maxine. This presentation is your online content on amputations. The associated reading for this section is in your IGGI textbook, Chapter 54, pages 1163 to 1168, and you can use your ATI for some quick study in pages 769 to 773. Before you proceed with this presentation, I just want to put a little disclaimer out that due to the topic we're talking about, some of the pictures I've included are a bit graphic, so you may want to be conscious of who may be around you that can see these images, as they may be disturbing to those who aren't in our profession. It may be disturbing to you as well, and for that I apologize, but some of these pictures I think are inducive to your learning. The objectives for this presentation include being able to identify the indications for surgical amputation, to describe the types and levels of surgical amputation. You also want to be able to understand various post-operative considerations for the amputee. You'll also be able to prioritize those post-operative and rehab nursing care for the amputee, as well as describe the nursing actions for surgical and phantom pain relief. Let's look first at the indications for amputation. The most common reason for needing an amputation is ischemia, and it's most commonly seen in the lower extremities. So the reason for this is there's this diminished blood flow or circulation to the leg, could be a result of diabetes, smoking, arteriosclerosis, peripheral vascular disease, gangrene, or other causes, and you'll learn more about these as the semester progresses. But just knowing that that loss of blood flow, the ischemia that causes tissue death, is really the primary reason. So here we see a patient whose heel has a sign of an ulcer, a wound of some sort, and the picture on the right here shows the effects of a patient who's had to have their distal part of their foot, their toes, amputated. Another reason for amputation could be trauma, and this is picture here that you're seeing is a traumatic amputation that happened, probably a motor vehicle accident or some other type of major trauma where the limb was actually pulled apart as a result of the trauma, and then the surgeon will have to go in and remove the residual bone and remove as much of the tissue necessary to save whatever they can of that leg. Another primary reason for amputation is thermal injury, such as frostbite as you see here, or severe burns. So with frostbite, we would expect to see the area turning discolored, usually purplish at first and then black, which may be an indication of pretty severe frostbite. Blisters may also form. There's going to be some nerve damage due to the lack of oxygen. If it's not treated immediately, that damage is permanent, can be permanent, can result in the amputation. You'll want to be checking it for any cuts or break in the skin. Check for any sensory changes, inspect the open skin, which could lead to gangrene. If the frostbite is caught early enough and it can be reversed, that's great, but if we don't catch it and we end up with these infections, then the amputation is most definitely going to have to occur. Some other reasons for amputation include infection that is untreatable or resistant to treatment. Most likely gets into the bone, and it's an occurrence called osteomyelitis. There may be tumors present, which may or may not be cancerous, but that could cause the need for an amputation. Your patient may also have some congenital deformities, things that they were born with, that may require amputation, especially if it was causing ambulation issues, circulation issues, quality of life issues. And then the final reason that you might see it is for basically intractable pain. And this obviously would be a last ditch effort to try to provide some comfort for the patient. There are several factors that the surgeon is going to take into account when determining the level of the amputation that's necessary. Ideally, they want to amputate as little as necessary, but they'll need to make some determinations first before they can make that call. They're going to first look at the functional part. They want to preserve the joint if possible. especially if they're considering or if it's suited for prosthetic devices. They want to, again, preserve the joint if they can, or at least as much of the limb as possible to allow for that prosthetic device to be fit. But they need to look also at muscle balance for the patient, what's going to be left, and will they be able to properly use that prosthetic. And one of the most important considerations is the blood supply for the stump. So they need to make sure that whatever is left is going to be properly perfused, that it's going to be able to heal properly. Obviously, necrotic or damaged tissue isn't going to heal quite well, and then the chance or the likelihood of infection, of dehiscence, of all these other complications of surgery are going to be higher if we're dealing with less healthy tissue. Let's take a closer look at the various levels of amputation, and I'm actually going to start from the bottom up. So a foot amputation or a transmetatarsal amputation would be used for issues with the toes or the lower part of the foot, and this type of an amputation would not permit itself for any type of a prosthetic device. The patients generally are able to ambulate with the portion of the foot remaining, but they are going to have some issues with balance, and there'll be, a lot of physical therapy and retraining, as we all should know the toes have a major impact on how we balance when we're walking. The next up would be the ankle or the ankle disarticulation, where the foot is amputated at the ankle joint. This also would not be conducive to a prosthetic device, but the stump is generally ideal for weight bearing once it's properly healed. The next level up is the below the knee or BKA amputation, also known as a transtibial amputation. This type of an amputation, the stump of about 5 to 7 inches of the tibia remaining is actually ideal for prosthetic fitting. Anything much larger sometimes can cause issues with circulation or improper fitting of the prosthetics. The next level up would be directly through the knee, which is called a knee disarticulation. The patella can either be removed or fixed in place to the cut surface between the condyles. It's most successful with younger, active patients who are better able to learn control of their prosthetic device. The next level up is obviously above the knee or AKA, also called a transfemoral amputation. And this one, as we go up the length of the leg and more of the leg is removed, it's going to cause more issues with ambulation, muscle control, weight bearing. And obviously, the older the patient, the harder it is going to be for them to eventually become weight bearing again. For example, elderly patients, if we're able to at least maintain the knee or part of the knee, it's going to maybe mean the difference between walking with a walker or cane versus being confined to a wheelchair. The next level up would be the hip disarticulation, where the leg is actually removed at the uppermost portion of the leg, and just slightly above that, and the most severe type of amputation of lower extremity is called the hemipelvectomy, where not only the leg is removed but a portion of the pelvis itself. Again, these are both very extreme cases. Patients who have lost, the entire leg and all or part of that side of their pelvis, they're going to have major issues with balance and function. The physical appearance is going to be a major issue, so they'll have some psychosocial difficulties as well. Now let's look at the different types of amputations. The first type we're going to look at is called an open or a guillotine amputation. And this is really the only procedure that will be done for a patient with an active infection of the limb. And it's done in such a way that it's left open to allow for that infection to drain from the area prior to healing, prior to closure of this wound. So this is really done in 2 different steps. The first portion being the removal of the infected part of the limb. Again, it's left open for drainage, but there will be some dressing. So you'll have to make sure that you Use very good aseptic technique when changing dressings so we don't introduce any additional bacteria or infection into the area. These patients will be treated with most likely IV antibiotics, and they will continue for more than likely a fairly long term to ensure that all the infection is gone. Once the wound seems to have relieved itself of the infection, then a second surgery will be done to create the flaps and closure of the amputated limb. The second type of amputation is a closed or flap method. In this particular type, which is the most common by the way, the muscles are divided at least 2 inches distally to the level of the intended bone dissection, and they're sutured under tension to the bone or the opposing muscle groups. This helps to protect the end of the bone. Drains are generally placed in this type of an amputation, one or more, and they're usually kept in place for about 2 to 3 days depending on the output. Skin is sutured with just enough tension to cause the ends to meet, but not so much that it's going to put undue pressure on that muscle underneath. And the suturing is done in such a way that it will not be impacted by weight bearing and it won't interfere with the prosthetic device. Now let's look at some of the preoperative considerations. First, there's a psychological preparation. Age is a pretty major factor in how well the patient's going to be able to cope with the loss of limb, and believe it or not, children seem to be better able to adapt than adults. We also look at emotional stability, whereas patients who have a history of depression or are currently in a depressed state are going to have a harder time coping with the loss of the limb. Patients need to be able to discuss their concerns and their fears. We need to give them an atmosphere in which they're able to voice all those because they are very legitimate concerns. And the nurse needs to assess the patient coping skills and their support system. That's going to help to with the recovery process. We need to make sure that if they don't have family or significant others to support them, that there are mechanisms in place that we can offer to help them get through their difficult times. Next, we're going to look at the prognosis. If the amputation is to cure a condition per se, they're more likely to have a favorable outlook after the fact, whereas somebody who it was an unexpected loss, like a traumatic amputation, they're going to have a lot more difficult time dealing with the situation. And that leads us to the circumstances surrounding. Again, patients who had time to mentally prepare for it in advance, have already had that anticipatory grieving period, are more likely to bounce back after the surgery a lot better than somebody who had to deal with it very abruptly, whether it be a traumatic amputation or something that they went in to have one procedure and found out that they had to take part of a limb as a result. Next, we look at the meaning of loss of the body part to the person. What does it mean to them? For example, are they going to lose their career, their ability to bring in finances and care for their family? Are they somebody who's in the public eye who now has to deal with this public loss of a limb? It's not only their own loss, but it's a loss to all those people around them. And then, of course, there's the change in body image, which is going to be a major impact on these folks. So again, knowing their knowledge base and knowing what health teaching needs to be involved preoperatively is going to help them. We need to look at their profession, their spiritual support, and all these different situations that are going to help us to plan our care postoperatively. And the next thing we have to think about preoperatively is what teaching needs to be done. So it's always a good idea obviously to make sure that the patient knows what limb is going to be amputated, and to teach the patient that as medical professionals, it's our job to make sure that we don't make mistakes, so that the surgeon and the operative team are going to mark the affected limb, and they're going to verify that numerous times before the patient is actually brought into the OR and put under general anesthesia. And again, that's for their safety, to make sure that we are doing what we're supposed to be doing and removing the limb that is going to be removed. So you can assure them that we're not doing this to scare them, but we're doing this to make sure that we're doing what is right for them, and that they should welcome that. And if people are not asking several times before they get into the OR, then they need to question that. Then we also need to do the, standard preoperative teaching. For example, talking about the need to turn, cough, deep breathe, using incentive spirometer to help reduce respiratory complications post-op. Inform them that they will be NPO, usually at midnight the night before the procedure, and how we're going to start to advance their diet after the surgery. It's a good time to talk about smoking cessation if that's applicable, especially in patients who are having this limb removed because of something like peripheral vascular disease that's attributed to smoking. You want to stress the fact that they're already losing one, limb or part of a limb, that they need to preserve whatever's left, and, doing some lifestyle modifications now is probably a good idea. Talk about pain management and how important that's going to be post-operatively. Because the better they manage their pain, the more able they're going to be able to do the other things that are required, such as, movement in the bed and early ambulation and all those other important post-operative things. Talk about doing foot pumps if applicable. Obviously, if they're losing their foot or feet, that's going to be something we'll have to modify. But talking about that, talking about SCDs, talking about the need for heparin to reduce chance of blood clots. Talk about the dressings that they're likely to have when they come out, so they're not, shocked by the appearance. Talk about the fact that they'll probably have one or more drains and what that's going to look like, and explain to them that the fluid coming out is normal post-operative fluid, that have the drains in place to reduce the edema, reduce pain, better manage the wound, etc. We want to talk about exercise preparation. So if able, they're going to want to try to get build up some muscle strength in as much as possible, so that they will be able to do that early ambulation, better able to mobilize themselves after surgery. The better shape and better physically prepared they are preoperatively, the more likely they are to have a quick and healthy recovery postoperatively. Talk to them about activities of daily living and how they may or may not be impacted by the loss of the limb that they're going to be losing. Talk about physical therapy and occupational therapy and various aids that can and would be used afterwards. For example, the use of a trapeze to help them with early bed mobilization. Talk about arm strengthening machines, especially if they're losing a lower limb. They're really going to have to work to build up their upper body strength. Other mobility aids like walkers, crutches. You could start to discuss the potential for prosthetics, although the physicians and the prosthetists will be in to discuss if that's something that's feasible, and they'll start to talk about the different options as far as that goes. Talk about especially this phenomenon known as phantom limb sensation or phantom limb pain. They will have post-operative pain, surgical pain, but they also may experience what's called phantom limb pain. We'll talk about this a little bit more further on when we're talking about pain management, but it is a phenomenon that is very real. They may or may not experience it depending on the situation. It's most likely and most normally seen in patients who have had a lot of preoperative pain, such as, the numbness, the burning, the neuropathic pain. Those are the folks that are most likely going to see this phantom limb pain, whereas the traumatic amputation, the immediate loss of limb for non-medical reasons, those typically don't see the phantom pain, but it is still a possible phenomenon. So let me talk just briefly about prosthesis. This is not something as a nurse that you're really going to be too too involved with, but it's a good idea at least to be able to recognize some of the terms and types of prosthetics that are available. And this is usually a discussion that goes on between the surgeon, the patient, and usually a prosthetist, which is a person who specializes in making these prosthetic devices. So some of the types that patients actually can come out of surgery with or will be wearing shortly after surgery are really the three here listed: the immediate post-op prosthesis, or an IPOP, early post-operative prosthesis, or EPOP, or the removable rigid dressing, RRD. And depending on the type of amputation, what level it's at, how much of the residual limb is left, and various other conditions that the surgeon, again, will decide on, will determine the type of prosthetic the patient will be a candidate for. There's also the standard prosthetic, where the patient will come out just with the stump, and after 3 to 4 months post-operatively, when the stump is sufficiently healed and all the edema is gone, it's at that point that they may be fitted and begin the use of the prosthesis. So there are various different ways that this can happen and types of prosthetics available. So let's just talk real quickly about these. So the immediate post-op prosthesis, it's a rigid, non-removable dressing, very much like a cast that's applied around the stump or the residual limb. Both terms, by the way, are politically correct. We still call it, for the most part, a stump, but residual limb is something that you might also see in literature or hear being used in practice. So the IPOP, it's applied either in the OR or in the PACU immediately after the surgery. It's left in place and changed after about 10 days of surgery, at which point the sutures or staples are removed and another cast is applied. When the stump volume is stabilized and it's healed sufficiently, then they would be fitted for a temporary prosthesis, and then several months after that, they would be fitted for their permanent prosthesis. So it's a little bit of a multi-step process. One of the advantages to these IPOPs and EPOPs is that they will be able to amputate full weight bearing fairly quickly, which again gives it an advantage, but not every patient is a candidate for this. So again, that's something that the surgeons really will have to decide. And sometimes it's not even decided finally until the actual procedure happens and they determine how much of the limb is left and what the vasculature is and the wound healing potential and all that is taken into account. The EPOP, or the early post-op prosthesis, is fairly similar, except that is applied usually about 5 to 7 days after surgery. So it's not as immediate as the IPOP, obviously, but it still allows for a little quicker ambulation than would a standard prosthesis. And then the removable rigid dressing, it's made pretty much with the same materials as the EPOP and the IPOP. It could be put on right after surgery. It does all the same things as the other two. It helps to control edema. It helps with the shaping of that residual limb. But it allows for better monitoring of the incision because it is removable. You can remove it, assess the incision, allows for better hygiene. The catch here is when you do take it off, you can't leave it off really for more than 20 minutes because it can cause edema to form in that limb and then it will no longer fit. And again, selecting the prosthesis, this is something the surgeon, patient, and the prosthetist will have to work out, and it's really just our function to understand the variation so that we can help answer questions when patients are asking. So for patients who don't meet the criteria of the previous slide and have the immediate post-op prosthetic or the early post-op prosthetic or the removable rigid dressings, they're going to come out of surgery with a standard post-operative dressing. And it's our job as a nurse to assess that immediately and then every shift. So what we would expect to see is, the stump will be wrapped, and exteriorly we'll probably see an ACE wrap or a stump sock over the surgical dressing. There may be many layers to the dressing depending on how much bleeding occurred during the procedure. Generally speaking, we don't change or address the dressing until usually the second day post-op after the surgical team has come in and assessed it. But then we will be routinely changing the dressing as ordered. One thing you will notice, usually the day of, the day after, is you might see some breakthrough drainage, serous-sanguinous type drainage, and that can be expected. It's something that we're going to monitor. That's when you get out your Sharpie marker and you draw around the drainage so that we can assess if it's spreading or increasing in size. That would let us know that there is some bleeding going on underneath the dressing. But we need to be alert to anything that is abnormal, such as large amounts of bright red blood, any pooling of blood underneath the stump, especially what we'll notice when we're turning and positioning or moving to do our assessment or do our patient care, bathing and whatnot. That is not normal, and that is generally going to be a medical emergency where you're going to want to get the surgeons called down immediately to assess the site. We're also going to be noticing and assessing the drains. Again, I think we mentioned earlier that they're normally kept in place 2 to 3 days post-operatively, and as nurses it's our job to assess not only the quantity of output and recording it routinely, but assessing the type of drainage. So initially we would expect to see sanguinous drainage or bloody drainage. It's a thicker red drainage, and then it will eventually convert to a serous-sanguinous, which is a much thinner, watery, could be still red or pink in color as it transitions from sanguinous to serous-sang to serous, which is going to be the straw-colored, looks really a lot like urine. We may or may not ever see it get to that serous color, but serous-sanguinous certainly is something we're going to start to see. And again, depending on the amount of drainage, that will determine when the drains are actually pulled. But it's our job to assess that every shift, make sure we're noting the quantity and the color, so we can get a good feel for what's going on inside the surgical area. Once the dressing is taken down and we're doing routine dressing changes, we're going to want to assess that suture line, look for any signs of infection, look for any signs of possible dehiscence. So whether it's held together with sutures or staples, we want to make sure that the edges look well approximated, that they're not abnormally reddened, or any signs of ischemia, dark tissue, failure to heal properly. We're also going to look for edema. Some pre-op or post-operative edema is going to be normal. We're going to do our best to try to manage that a number of different ways. First of all, that ACE wrap or stump stocking is designed to really apply some compression, not so much so that we're going to impede vascular flow and nerve flow, but enough that it's going to help to manage that edema. We check for swelling at the proximal end of the stump or the residual limb. But again, we want compression in the dressing, but we don't want it so tight that it's going to cause ischemia, which can actually threaten the stump itself and cause us to lose even more of that limb. Ice packs generally are still recognized as an acceptable method for helping to control edema, control inflammation, which is going to reduce pain. But that's something that, unless it's contraindicated, you should be able to use fine. I know that once you're out in practice, you'll find some surgeons have preferences as far as if ice is allowable and to what extent it is. But it's still generally accepted practice that we as nurses can apply ice. Just making sure that it's on for no longer than 20 minutes and then off for about the same amount of time before we reapply. We'll also talk about later on positioning of the stump. We don't want to elevate the stump on pillows because that can cause some hip flexion when that stump is elevated for too long of a period, but we can elevate the foot of the bed, and that can also help to reduce some edema. And we're also again looking for signs of infection, any unusual bleeding, any signs of abscess or purulent drainage, either in the dressing or in the drains. Be alert of any unusual or abnormal odors that may indicate infection. And again, once the original dressing is done and we're doing routine dressing changes and stump care, you'll want to, palpate, and if you feel any areas of abnormal heat, that could be a sign of some infection brewing underneath the surface. And any of those issues, you're going to want to alert the surgical team as soon as possible. Another very important postoperative consideration for us nurses is pain control. As we talked about earlier, these patients are likely to experience two different types of pain specifically: the surgical or incisional pain and the phantom limb pain. So surgical pain, is managed pretty standardized with analgesics, could be narcotics or nonsteroidal anti-inflammatories or a combination, as well as the use of ice or cold packs. But here's where it's really important that we do a good nursing pain assessment, having the patient describe the pain. Where is it? What does it feel like? Have them give you some descriptors, because surgical pain and phantom limb or neuropathic pain are distinctly different, and they are treated very differently. Obviously, if they're complaining of pain, you can always treat with analgesics or the narcotics or whatever's ordered first, but be aware that that may not have much effect, especially if we're dealing with the phantom limb pain. So for that particular types, again, I said it's treated very differently. One of the most common pharmacologic treatments is at least anticonvulsant medicines such as Neurontin or gabapentin. We can also use the nonsteroidal anti-inflammatories as well. Certain tricyclic antidepressants are known to have good effect of this phantom sensation or phantom pain. Narcotics may provide some relief, but again, they're not typically used to treat the phantom limb, but always a good idea to start with that, especially if you or the patient is unsure of the actual cause of the pain. Ice is great with the surgical pain, but hot packs or warm packs are also found to be very effective for the phantom limb. So if one doesn't work, you can always try the other. So as I previously mentioned, postoperative positioning is extremely important in proper healing, as well as postoperative exercise. So one of the biggest priorities here is to help prevent hip contractures, which can happen from prolonged sitting, prolonged contracting of that muscle, especially with the lower extremities we're talking. So one of the things we can do is, when the patient is in bed, is to have them lay flat versus in a sitting or upright position, semi-Fowler's or Fowler's position. We never want to use pillows to elevate the stump. Again, if we're worried about edema or trying to control it, then it's best to elevate the foot of the bed in Trendelenburg's position versus elevation of the stump. For short periods of time, initially, maybe the first 24 hours, it may be acceptable, but again, it has to be for short periods, and really not recommended if at all possible. It's also a good idea to have the patient lie prone 2 to 3 times a day, meaning on their stomach, starting out with maybe 10 minutes at a pop and increasing it up to 30 minutes. And if they do that, 2 to 3 times a day, that's going to help to again, prevent those hip contractures, which is very important, especially if the patient is somebody who is probably going to be fit with a prosthetic and are going to want to have, kind of a normal quality of life afterwards. Again, no prolonged sitting, so whether it be in the bed or chair or wheelchair, it really should not be for very great periods of time, only like during meals and very rarely in between. And when possible and practical, to get them up and ambulating, whether they have a prosthetic or not, there are still, assistive devices that can be used to get them up and moving. Allowing the stump to be dependent or lower than the level of the heart, helps to encourage blood flow to the stump and the wound, and allows it to heal better. Stump care or stump conditioning is also a very important aspect of postoperative care. And it's really to help, again, manage edema and properly form the stump or that residual limb to better be able to fit the prosthetic device. So as we talked about earlier, it's usually done with an ACE wrap, or at least initially, and then once the stump is a little bit better healed and better formed, we can use a stump sock. These two diagrams on here show you basically the way it's done, always starting with the distal end and working your way up. It's done again with an ACE wrap using a figure 8 type of wrap. We want to use enough compression to help reduce the edema, but not so much that we're going to compromise blood flow and cause ischemia to the limb. And to that end, we're going to make sure that the wrap we're using is 4-inch or 6-inch, nothing smaller. The smaller it is, the more likely it's going to put undue pressure on the limb and cause ischemia problems. So 4 inch is the smallest diameter ACE wrap we'd want to use. And again, it's going to be using the figure 8 starting at the distal end, applying some compression, and we're gradually going to decrease that amount of compression as we go up the limb. So we definitely want to make sure that the patient is not complaining of discomfort. And while it's wrapped, trying to do good CMS checks as much as you can. You may not be able to palpate pulses in the usual places, but you still want to check for warmth and color, during and after the wrap is applied and removed. Rehabilitation for these patients is going to be a huge part of their postoperative consideration. This has to be a team approach. This has to involve not only the patient and their family or significant others, but the physician, the nurses, occupational therapy, physical therapy, the prosthetists, social work, chaplains. Anybody who is part of this person's team needs to be involved to discuss, what should be done, what needs to be done, treatments, therapy, assistive devices, support services. All of that needs to be addressed. It needs to start while the patient, ideally before surgery, but at the very latest, after surgery, before discharge, we need to start having these discussions. We need to do a lot of care for the patient and the family about stump care. Not necessarily, but typically by the time they leave the hospital, the wound is fairly well healed. They may still be using the ACE wrap for stump care, or they may have progressed to an easier mechanism such as a stump sock, a limb sock. They may or may not have their prosthesis at this point, but they need to be instructed about the proper care of it. That's generally done by that prosthetist, the person who specializes in it. But we as nurses need to remind our patients that wearing the sock, the limb sock, it's necessary. It helps to absorb perspiration. It helps to avoid contact between their skin and the prosthetic socket, and helps to reduce the chance of skin breakdown, which would cause them to not be able to wear the prosthetic, which is going to delay the rehabilitation. So we need to really drive these points home. We need to talk about ambulation and progressive ambulation. Again, that's something physical therapy and occupational therapy will probably address, but it is our job to reinforce that teaching so that the patients know what is expected and what they're required to do. And good teaching about needing to care for the remaining extremities. If they lost one foot or lower limb or upper, above the knee amputation, whatever it is, if they lost it because of diabetes or peripheral vascular disease, we need to talk about that, the fact that their other limb is just as vulnerable, that they need to do, really good foot care, nail care, skin care, lifestyle modifications necessary to live a healthier life so that they can take whatever they have remaining and live a good long life. So teaching needs to be constant, continuously reinforced, positive. We need to be proactive in this. So to kind of summarize up what we've been talking about, if you haven't already noticed, nurses have a lot to do with regard to the amputee, dealing with the patient, caring for the patient that's had an amputation. So there's the psychological or physiological adjustments that the patients have to make, and we need to be there to help them with whatever support and services they need. We need to help them to manage pain, teach them how to manage pain. So that they are able to do all those activities that we need them to do to facilitate better healing. We need to teach them about prevention of complications, why we're giving them heparin or Lovenox shots, why, we're using a compression stocking on their residual limb, and why they're wearing an SCD machine on their other limb. Why mobility and functional status is important, and what tools they have at their disposal to help to facilitate better mobility and improve functional status. And we need to talk about prognosis and think about their treatment needs and what they need moving forward, ensuring they have support systems. And if they don't have them in place, we need to help them to find support systems to get them through so that they're able to have a quality of life. And finally, we'll look at just a couple of the NANDA diagnoses that are applicable for this patient. So first and foremost is the risk for trauma, and that would be related to balance difficulties or altered gait, muscle weakness, reduced muscle coordination, lack of safety precautions, and hazards associated with the use of the assistive devices that they need. So that's going to be a big nursing problem for these patients, and something that we really can make an impact on. The next one would be disturbed body image and or situational low self-esteem, which are both kind of psychosocial diagnosis, and that would be related to loss of body part and change of functional abilities. And there are really a lot of things we as nurses can do to help patients get through this. And the last one we'll talk about is self-care deficit and or impaired home maintenance, and that's related to musculoskeletal impairment, decreased strength or endurance, pain, and depression. And that's as far as we're going to take this presentation. If you would like a printout of this presentation, just look at the directions below and then you can print out a copy and take notes. Listen to this as often as you need, and happy studying.